Welcome to the American College of Surgeons Bulletin Brief from the front lines, Surgeons' Voices. With me today is my dear friend, Professor Lenworth Jacobs. Dr. Jacobs is a professor of surgery at the University of Connecticut and is an immediate past regent. I had the pleasure of serving alongside Dr. Jacobs and learning much from him over our 7 or 8 year overlap on the Board of Regents. Welcome, Len.
Well, thank you. It's a pleasure to be with you. And I too want to say it's been fun working with you for this last 7 or 8 years. It really has.
It's one of the wonderful things, one of many wonderful things about the college, that the House of Surgery, that you get to work, me as a colorectal surgeon, you as a trauma surgeon, Scott Levin as orthopedics, and John Atkinson in neurosurgery. You get to work with people in all different disciplines who have a similar passion for advancing surgery and patient care. It's just a wonderful organization. And we come at it from very different angles, what we do for careers. And your career has just been recognized by the highest distinction given by the American Surgical Association, the Medallion for a lifetime of achievement. And maybe you can show us that medallion that you just received from the American Surgical.
Well, I'm greatly humbled and honored by it. This is the medallion here. And yeah, it's pretty nice. Distinguished service to surgery. So
it's an incredible achievement, and I think at least part of it is for the creation of the Stop the Bleed program. So congratulations on the recognition for what you've done through your lifetime for trauma, including Stop the Bleed. And I'd like us to focus for the interview about that program, the Stop the Bleed program. Perhaps you could start off telling us a little bit about what is the program and the history of the program.
You know, it has a dark beginning because it really came out of Sandy Hook and the shooting in the Newtown Elementary School and the Boston Marathon. So those are two mass casualty events which were significant. But what is really important is the response to it. And the Board of Regents basically said we should do something about this. And they established a committee to increase salvage, if you will, from mass casualty events and active shooter events. That was the genesis of it. And it immediately became apparent that if you want to do something to stop bleeding, you need to do it immediately. You need to really do it as fast, as soon as a person's injured, because if you can keep the blood inside the body, you'll have a better outcome. And the way it was set up before is the police would respond, they would secure the scene, but they're not medical people. They would call for, fire would probably be the next on the line and secure the place. And then emergency medical services would come in, but they would be held back until the scene was secure and so forth. So all of that meant that there was a lot of time lost. So if you were bleeding seriously, you would have a significant loss of blood by the time bleeding was stopped. And we felt that we need to get to the heart of the problem. The patient's bleeding, stop the bleeding. And who's going to do that? The person closest to the patient. So that became the public. And in the same way that if you have a heart attack, the person next to you hopefully does CPR, same deal. If you're bleeding to death, the person right next to you is going to stop the bleeding. So that ended up really coming through with how could we empower the public? And this is a big deal. So we got involved with the White House, National Security Council, the US military, who deals with this all the time, the FBI, fire, police, and then the emergency medical services group and the hospital group. So it's a very disparate group. And probably the most important thing was that each one of these domains has a different reporting system and a different command structure. Police report to police, fire reports to fire, EMS reports to EMS. So who's in charge? And when you sort that out, you waste time. So we wanted to empower the police to also stop bleeding. So that meant training and equipment. empower emergency medical services to be faster, quicker to the scene. And then most importantly, train and empower the person right beside you to stop bleeding. And that's not particularly easy because that person has probably never seen severe bleeding. And if you're bleeding severely, you're probably hurting. So it's a very difficult situation to put the public in. But we polled the public, and 95% of the public said they would be prepared to stop bleeding if and they didn't even have to know the person. So we thought, well, the public's pretty altruistic. Let's develop a training program and empower them. And that's basically what Stop the Bleed did and is.
Fantastic. Could you please describe for us the elements of the training program, like what's in the kit, how long does it take to train, who does the training?
Yes, well, again, in asking the public, we said, how long will you give us? This is just Joe and Jane public. Doesn't know anything about medicine. They said 1 hour between church and lunch, and between the lunch and the ball game, 1 hour. So we had to develop a program which would teach you the rudiments of what bleeding was all about, arterial and venous, and then teach you the psychomotor skills to hold pressure, put on a tourniquet, and put a hemostatic dressing. And we borrowed liberally from the military. They were very good at this. Every soldier that goes to war is trained to stop bleeding, has a bleeding control kit on them, and is empowered in the quote buddy system to stop and help an injured soldier and move on. So that's really what it's all about. Use your hands to stop bleeding. Use something, a shirt or whatever you have, until you have a hemostatic dressing. Press it hard on the wound and then use a tourniquet. And that's it. So and then of course the kits, which we want to be in all public places. We haven't completely succeeded in that, but that's what we want. Certainly in stadiums, in convention centers, in hospitals. Most law enforcement people now could carry bleeding control kits on them. And so we're slowly getting there. And we have 85,000 instructors in 123 countries, and we've trained 1.6 million people. So it's not, we wanted to train 200 million. We're not there yet by any stretch, but it's a start.
And who currently owns and administers the program?
Well, it's interesting because the American College of Surgeons provides the intellectual drivers for this. So we partnered with the military and with the pre-hospital people and ourselves and developed the training program. We also provide a certificate of completion and competence to everybody who goes through the training program. And that is important because if you stop to help somebody and somebody says, well, what are you doing? You can pull out your card in the same way that it's a CPR card and say, I'm trained, I can do it. So we train them, we empower them, and we give them a credential.
So the next question is, you've trained 1.6 million people. Are you aware of instances in which the skills have been used?
Very much so. Frequently, both not only in the things which you read about in the papers, mass shootings, Las Vegas, Orlando, etc., where they are used extensively, but probably much more commonly, people who cut themselves with a chainsaw or a kitchen knife, or fall on a stake, or a kid in a school drops off, onto a stake or something. And there have been way more than anecdotal reports of people who have been, we can't say that the training or the equipment saved their lives. That's not appropriate, but it's certainly decreased morbidity and mortality, because obviously they have to get to the hospital and then definitive care. So we can only say that we are keeping blood inside the body and we're giving the patient a much better chance.
That's outstanding. That's wonderful, wonderful work. How about outside of the United States? Has the program gained traction in other parts of the world?
It really has. The Committee on Trauma has uh, offices or agents throughout the world. Um, and they really need a pat on the back, because what they've done is they've taken this and run with it. So it's in South America, in the Middle East, in the East, in Europe, it's just in Canada, it's all over, 123 countries. We have instructors, and they're training and performing in all of those places. So, it's a simple skill. We've even trained the Boy Scouts in it at the Jamboree. So it's a simple skill which anybody can master, and they'll have it for the rest of their lives.
Well, I know you've trained a lot of governmental officials, that you've gone and trained legislators and the like, and have they become good proponents and advocates thereafter?
Yes, they have. Um, and we go both sides. So Representative Scalise, Representative Lee, both from different sides of the aisle. They have both come to the training program. They're both strong advocates for it. In my own home state, Senator Blumenthal has come to our center, and we've had the pleasure of training him, and he's a strong advocate for it. So not only do they advocate on a personal level, but there are laws now. In Texas, you have a law, OSHA, the um, environmental, the occupational health agency, they've become involved. So we're definitely getting out through the legal or the law making agencies to pay attention to this.
In addition to agencies, there are other groups where one would think the kits belong, and employees should be trained, whether that's, highway patrol, the automobile industry, whether that's people working in, you mentioned convention centers, but in airports, other places. I mean, there are first aid kits in many cars. How about a stop the bleed kit in a car?
Well, one of the things which we're trying, we have not been universally successful. We're trying to get a kit in every car, so that where do I find one of these? Look in your glove compartment. And that's our goal, because if you do that, then people don't have to worry about getting it or going to a box or finding it somewhere. It's there, number one. Number two, we're also trying to use the rear view screens in the cars as training tools, so that you got about 8 to 10 seconds. And in that 8 to 10 seconds, you can train people how to hold pressure with your hands, how to use a tourniquet, and you can do that pretty effectively.
Fantastic. Well, again, it's an absolutely wonderful program that's been developed, and that you championed. And memory serves correct, I think you went with Dave Hoyt and others to the Rose Garden at the White House at some point when the program was inaugurated. When was that?
That was in, I think, 16 or it's 15, and that was quite a amazing kind of event. But I do want to say that there are a lot of people who have been involved in this, and they should also get the recognition, because this is not a one-man show. It requires the entire Committee on Trauma, and then all these other partners, both in the government and in industry and private sector, to really make it come alive and to empower the people. So thanks to them.
Well, that's very kind of you. And in the last minute or so, if you want to add any other remarks, please do before we wrap up.
Well, I just think that this is such a simple thing to do. It's easy to learn, it's very effective, and it's very inexpensive. And there are very few things that make a difference, which the public can do. Doesn't cost a lot of money. And when you do it, it has immediate effect, which helps the patient, but it also helps you. You feel good about yourself, and you feel good about being a reasonable and nice and gentle human being. So that's probably the one legacy which I think helps everybody.
It's a huge legacy, and I'm thrilled for you. And again, congratulate you on your very well-deserved recognition, albeit, as you say, a shared recognition by the American Surgical Association. Congrats, and I hope to see you in person one of these days.
Indeed. Thank you so much. Have a wonderful night. Take care.
You too.